Here we discuss about our initial approach after a diagnosis of HIV in a patient is made. All HIV positive patients should receive antiretroviral therapy because it reduces transmission, it improves immunity, and it reduces HIV related morbidity and mortality. So this is irrespective of the CD4 counts. The only problem is when we consider an immune reconstitution syndrome, we might have to wait before we start antiretroviral therapy. The therapy targets are to have undetectable HIV RNA levels, and also we look at improvement in the CD4 counts. Do an initial basic workup, look at all vaccine preventable issues, and for follow up, it is the HIV RNA levels because undetectable RNA levels is the goal of therapy. We should consider drug resistance testing for reverse transcriptase and protease inhibitors in all patients, and for INSTI resistance, which is integrate strand transfer inhibitor resistance, for selected ones where we suspect the presence of resistance. When a drug regimen is changed, it should be done at the earliest within 4 weeks. So whenever we change a drug either due to toxicity or inefficacy and a new drug is introduced, we should do the testing because the presence of replicable HIV RNA in the blood helps in detection of drug resistance. And if not done at the same day, at least within 4 weeks we should do it. CD4 count helps in deciding on prophylaxis for opportunistic infections. CD4 count also helps in the differential diagnosis of opportunistic infections because at different CD4 levels, the risk for certain diseases increase. What about the chemoprophylaxis? PCP, which is pneumocystis carinii prophylaxis, for all patients below a CD4 count of less than 200 or less than 14% of the total count. Trimethoprim sulfamethoxazole double strength or single strength once daily is the dose that is given, and the alternatives if the patient is allergic are dapsone with or without pyrimethamine, leucovorin, atovaquinone, and pentamidine. For toxoplasma, it's less than 100, but the same drug trimethoprim sulfamethoxazole is helpful for toxoplasma as well. Latent TB, where when the patient is having latent TB, you have done a screening test or there has been a close contact and the patient is always on antiretroviral therapy, we may consider latent TB therapy. You have to rule out that there is no clinically present tuberculosis, so it is only latent, and the regimens which are given are multiple. One of the suggested ones is INH at 300 and rifampicin is 600 milligrams once daily for 3 months, and there are weekly regimens also with INH and rifapentin. For MAC, it is CD4 less than 50. So mycobacterial avium intracellular complex, which is there, it's seen with more progressed immunosuppression. If ART can be started or suppression is achieved, then there is no therapy which is recommended. Otherwise, macrolides are the cornerstone of therapy, and azithromycin 1200 weekly is something we can consider. Coccidioidomycosis, histoplasma, malaria, tularomycosis, these are more specific recommendations depending on regional variations, geographic issues. So these are meant for a particular set of patients. What about the initial choice of antiretroviral therapy? Now we have to choose combination antiretroviral therapy, and the 4 groups which form the core for therapy are the NRTIs, nucleoside receptor analog, the non-NNRTI, non-nucleoside receptor analogs, the integrase strand transfer inhibitors, INSTI, and protease inhibitors, generally boosted either with ritonavir or with cobicistat now. The 2 NRTIs and 1 INSTI is generally the standard because INSTI has changed the entire scene in HIV, as the resistance to these drugs is very small, and also they have enhanced clearance of the HIV virus. They do it faster, and dolutegravir is now almost a stable part of the regimen. It is also available in the Indian NACO guidelines as the drug of choice. And 2 NRTIs, what you have to choose from is tenofovir, either of the salts, tenofovir alafenamide or tenofovir diproxol, and lamivudine or emtricitabine. Both have similar mechanism of action, so you pick either one of them. So this generally forms the first favored combination therapy, 2 NRTIs and 1 INSTI. When an INSTI cannot be used, boosted darunavir may be considered. And darunavir is a protease inhibitor. What are the other NRTIs? Abacavir and zidovudin. Abacavir, because of the issues of skin reactions, it is not a first line agent. We use it as a second line if one of the other NRTIs cannot be used. And zidovudin, it is still available as part of the NACO guidelines. It is more versatile, can be used in pediatric population, is available in different formulations, but is still a second line drug. What about the NRTIs? They are not now recommended as the first line drug because INSTI has replaced them, and mainly this is because of the presence of resistance to these drugs. But the ones which was used extensively was efavirenz, and it's still one of the drugs that finds itself in a lot of combination therapy. The other ones which are there is nevirapine, rilpivirine, doravirine and delaviridine. Among the protease inhibitors, we have ritonavir, darunavir, atazanavir, generally boosted with ritonavir or cobicistat. And this boosting is required because all of them are inducers of the cytochrome P450 system, which causes enhanced clearance of these drugs. And ritonavir and cobicistat are two inhibitors. So what they do is they make the drug more stable, they decrease the clearance of the drug, and now it's a standard to give them with boosted therapy. We need to understand that one of the major problems with protease inhibitors is the drug interactions and also metabolic side effects. Cabotegravir is a long-acting INSTI and rilpivirine is a long-acting NNRTI available as long-acting injectable preparations and have been used with patients with suppressed HIV RNA levels. So now we are into a stage where we are using injectable drugs for prophylaxis also and for treatment as well, only in patients who have undetectable HIV levels because of some other drug regimen and we want to change them over. This is also an option, and this is done once every month or two. So of all the HIV drugs, we need to know most about tenofovir and lamivudine, and we know both are also anti-hepatitis B drugs. We have used them for other reasons till now. And the one drug we need to know about is dolutegravir, which is an INSTI. The other INSTI which was available, which is called first generation, is raltegravir, and a newer one is come which is bictegravir. NRTIs and INSTI form the core therapy, and when we need a replacement, we add an NRTI, and protease inhibitors can also be added, but they are generally the second choice after this initial choice has failed. So we might come across patients who are on antiretroviral therapy receiving these drugs. We need to understand what drug interactions they can have, what are the major side effects that they can have, and how do we continue these drugs in the presence of organ dysfunction.